Welcome, everyone, to the future of federal healthcare policy, what to expect under a second Trump administration. Glad to have all of you here today. I am Ari Markinson. I'm a partner here at Venable in our New York office in the corporate and healthcare practice groups. Do a lot of healthcare M&A and healthcare regulatory work. Really happy to be moderating a discussion with a lot of my colleagues who are real experts in the area. And what I'm going to do is start with asking everybody to just give a quick intro, and then we'll get into some meat of our discussion. So, Jody, if you could start us off.
Great. Thanks, Ari. My name is Jody Curtis. I'm a senior policy advisor and co-leader of the Health Policy Group here at Venable that sits in the Legislative and Government Affairs Group, and which is a group of about 30 professionals and lawyers, including former Congressman Bart Stupak, former Congressman Mike Capuano, and joining us just Monday, former Senator Dean Heller. So happy to be with you. Keep an eye on the federal health policy landscape.
Great. Elisa.
Sorry. Greetings, everyone. I'm Elisa Halpern-Paul. I'm a senior policy advisor at Venable, and I joined Jody in co-leading the firm's healthcare policy team. Great to be with you today.
So much. Why don't we move on to John?
Hey, John Rizwicki, also in the government affairs policy group here. Did 11 years on Capitol Hill before coming here, all with the House Republican side. So thanks.
Great. Thank you, John. Valerie.
Greetings, everybody. I'm Valerie Cohen, a healthcare investigations, litigation, and regulatory compliance partner based out of Venable's New York office. I help companies and individuals in the healthcare space understand whether and which of the many, many laws they may have to comply with, and I defend them if a regulator, whistleblower, or somebody else comes knocking on their door. Happy to be with you all.
Thank you, Valerie. And Jeremiah.
Hey, good afternoon, everybody. Thanks for joining. My name is Jeremiah Kelly. I'm a partner in the Food and Drug Law Group here in our Washington, D.C. office. I spent 8 years in the commissioner's office at the U.S. Food and Drug Administration. I served 3 different commissioners there. I joined Venable in early 2020, 2023, after 12 years as a senior DOD food and drug law attorney. So I help clients navigate the complexities of the medical products paradigm administered by FDA and all of our sponsor clients' weird R&D interactions with the U.S. federal government. So I'm glad that you're here, and I'm so glad to be part of the team.
Thanks, Jeremiah. Now let's get going. Jody, we're going to start with you in our conversation here. And so the end of the 118th Congress was a bit of a seesaw with a healthcare package and then no healthcare package. And can you give us a recap on sort of where we ended up?
Yeah, thanks, Ari. I think it's important to kind of just do a little look back because it's going to have an impact on what the next year or two looks like. So I think most people probably know, but just in case, traditionally there's an end of the year health package that happens because there's certain provisions, usually Medicare payment provisions that are going to expire and need to be extended. So they usually put a package together and then other items get tossed onto that. And sometimes it grows a lot, sometimes it stays small, but there's usually something. And this year was no different. After a lot of negotiating, a package was put together to ride along with that end of the year appropriations package they were going to do. And it had a lot of provisions that people have been working on over the past couple of years in Congress. It had, just for instance, disproportionate share hospital payment extensions, pharmacy benefit management reform provisions, Medicare extensions for low volume hospital payments, Medicare dependent hospitals, alternative payment models, incentive payments, a partial fix to the physician fee cuts that happened through rules and regulations, an extension of the telehealth flexibilities that were granted during COVID, a hospital at home waiver flexibility extension, community health centers, funding extension, graduate medical education extensions. A lot of those, some were 1 year, but most were 2, 3, or 4 years. In addition, there was something called the Support Act, which was an omnibus and is an omnibus substance abuse and mental health package that folks have been working on for a couple of years. For those that are concerned about preparedness, there was a Pandemic and All Hazards Preparedness Act reauthorization, and then other reauthorizations on maternal health, cancer, research, priority review vouchers, healthcare provider protection legislation. And then, as we all know, it blew up. Series of texts and other things, and we ended up with a continuing resolution that had a very small, what I would call must-do package, extending certain provisions that were really about to expire only for the length of the CR, so only through March 31st. So those telehealth waivers, community health center funding, those Medicare extensions, the graduate medical education, the Pandemic and All Hazards Preparedness Act got a very short window extension, which leaves many things to be done by the 119th Congress. And I know my colleagues will talk more about this. Some of it can be done through reconciliation because they add or detract from the federal budget. And matter of fact, some of them are scored as savers, so they're going to be very attractive for that process. But others don't fit into reconciliation, and Congress will have to decide how it wants to handle some of those provisions. So that's kind of where we ended up as we cruise into January of 119th Congress and a new Trump administration, Ari.
Jody, thank you. Elisa, let's grab you to give your perspective on some of the major health policy issues that the new administration is focused on. What do you see some of what do you see as some of the top issues that the administration you think is going to be focused on?
Thanks, sorry. I think we could spend the whole hour unpacking it. So I'm going to focus on just a handful of issues, and then I think we'll hold some time at the end in case there's likely topics that Jody, John, and I are not going to cover in our brief overview if people want a deeper dive or if there's something that we don't mention. So I think what's particularly interesting as we look at the incoming Trump administration, HHS, and specifically the Centers for Medicare and Medicaid Services, CMS, are some of the dynamics that I think are going to be at play. So Dr. Oz, who's been named to head up CMS, interestingly, is the first physician administrator in quite some time. In fact, I had to go into the Wayback Machine or use Google to refresh on the last time we had a physician, both under Democrat and Republican administrations. So it was 2004 when Mark McClellan, a physician, was named and appointed to be the head of CMS. So that was the George W. Bush administration. And Dr. Don Berwick, under the Obama administration, ran CMS for 2 years in 2010 and 2011. So it's been a long time since we had a practicing physician at the head of CMS. And I think a lot of folks in the provider community are really excited about that, to again have a physician leader in charge of that agency. We don't yet know who's going to be running the Center for Medicare, the Center for Medicaid, or the Center for Medicare and Medicaid Innovation. So those additional 3 players will give us further insight into how and where the agency plans to go in the next 4 years. But with Dr. Oz at the helm, ostensibly, presuming he's confirmed by the Senate, there's several things that he's lifted up as areas of priority or interest for him. One is he's spoken very vocally about a Medicare Advantage for all. So not Medicare for all, but Medicare Advantage for all. So really wanting to double down on Medicare Advantage, the private plans for individuals who are covered by the Medicare program. He's also a real advocate for telehealth, for digital health and other innovations to expand access and improve outcomes and quality for Medicare beneficiaries. So those are a couple of things that we know about Dr. Oz. With respect to other issues that we anticipate the Trump administration, CMS in particular, having on the roster, there's a few that I wanted to mention today. One is site neutral payment, which I think John will probably talk about it from the perspective of the Congress, but this is CMS reducing payment under the hospital outpatient prospective payment system known as the HOPS to physician fee schedule rates. CMS already has several areas where it has imposed site neutral payment, both through direction of the Congress as well as through its discretionary authority. The Medicare Payment Advisory Commission in June of 2023 had a chapter that enumerated 57 specific services where the commission believed that site neutral payment would be appropriate. So even if the Congress doesn't do site neutral, we anticipate that the CMS will at least be looking at this and examining where and if it wants to reduce reimbursement for certain services under the OPPS to that physician fee rate. Saves money. However, when CMS does it, the Congress doesn't get the score. And as Jody said, many of these ideas are savers or pay-fors. And so often Congress wants to utilize those to pay for other things. So I'm sure John will give us some additional insight with respect to site neutral payment in a few minutes. The other that I wanted to mention is Medicare drug price negotiation. So the first Trump administration, many may recall that President Trump was very vocal and a very fierce advocate about prescription drug prices, not just for individuals in the Medicare program, but all Americans. He put forward a very robust, comprehensive plan for ways to reduce the cost of prescription drugs for Americans at the pharmacy counter. It did not come to fruition, but it was put forward as a key area of policy change that he wanted to pursue. The Inflation Reduction Act included the ability for CMS to negotiate prices, as everyone knows. Congressional Republicans have not been big fans of that, and John can give us his view. I don't think it's ripe for reform, but it remains to be seen how the Trump administration is going to handle that. On the one hand, you could envision incoming President Trump wanting to do even better than the Biden administration with respect to negotiating drug prices, since he is a businessman and somebody who prides himself very much in being a very strong negotiator. On the other hand, there's not a lot of love for the IRA provisions. And so because a lot of this is mired in the courts right now, we are not yet sure how the Trump administration is going to handle the pending court cases and whether or not it will maintain the position of the Biden administration in defending the IRA or taking a different position going forward. So we're going to be looking at that, for example, as an area of previous policy priority for President Trump, and to see how that plays out as they take the reins. And the third I wanted to mention is Medicaid. Medicaid covers about 70 million individuals. It's over an $800 billion, I think $850 billion program annually. And as Willie Sutton famously said, why did you rob banks? It's because that's where the money was. As Jody mentioned, the Congress is going to be looking for areas to cut and to pay for things. And Medicaid is one place where the money is viewed to be. In the previous Trump administration, they promulgated a proposed regulation called the MFAR, the Medicaid Fiscal Accountability Regulation. That would have put forward several changes to the Medicaid program. It would have changed supplemental payments, both reporting, the mechanisms by which states can draw down additional funds through matching. It's very wonky and very detailed. It also was not very well received by states and those who are big fans of the Medicaid program. There could be an MFAR 2.0 that could come forward since it was never finalized. It is, again, an area of interest. State plans will be reviewed by CMS, and that's another area where we anticipate the Trump administration wanting to have great involvement in reviewing those state plans to determine if the areas in which states are seeking to go is aligned with their priorities, including, for example, work requirements. We also know that there's changes being discussed in the Congress vis-a-vis Medicaid, like block grants, which I'm sure, again, John would be happy to talk about. And then the last, just in the interest of time, is transparency. Again, we know that this was a priority for the first Trump administration. We saw two major things happen under the Trump administration with respect to healthcare pricing transparency. The first was to promulgate requirements that hospitals post on their websites a machine readable report of the cost of a certain set of services and procedures. And then also the No Surprises Act, which was enacted by Congress, was signed into law. And then the Biden administration has had the responsibility for implementing that. The implementation of the No Surprises Act has not necessarily gone as well as people had hoped. And so we anticipate that the Trump administration coming in will take a look at that and seek to improve or reform or modify the manner in which that has been implemented, as well as the transparency requirements, since that was a real priority for the previous Trump HHS. Of interest, recently, the Government Accountability Office did an assessment of the HHS transparency requirements and noted and made a set of recommendations to CMS about how it can ensure that the data that are being reported are useful, and also noted that CMS might wish to engage in additional enforcement actions. So again, that might be something that the Trump administration looks at and seeks to act on. And then I would be remiss if I didn't at least acknowledge the nominee for HHS Secretary as RFK Jr. I'm sure everyone listening today has read a lot about him and his priorities. He obviously is very much focused on making Americans healthy again, focusing on preventing chronic disease, improving nutrition, improving the foods that people eat, getting Americans to exercise. He's also very interested in examining vaccine safety data, as well as reforming and reorganizing public health and medical research agencies like the Centers for Disease Control and Prevention, Food and Drug Administration, and the National Institutes of Health. Some of that he can do under executive authority, but some of that will require the cooperation of Congress, which John can speak to in a moment. So with that, in the interest of time, I'll stop. Thanks, Ari. Appreciate it.
Elisa, thank you. And as you've foreshadowed several times, we're going to move on to John. John, so new Congress, slim majority in the House. What are we likely to see from Congress on healthcare policy?
Yeah, well, I think the package that was, floated around in the end of December is the starting point. If you listen to Energy and Commerce Health Subcommittee, Buddy Carter, they want to move that through pretty quickly. Like Elisa and Jody said, anything that kind of will save some money, they'll want to throw into reconciliation. We talked about site neutral. I think it's about $200 billion there. You got the ACA subsidies, which has been talked about a lot, that were expanded. It's like $65 billion there. They're going to try to take anything that saves a little bit of money and put it into reconciliation, because they're going to try to offset that as much as they can. I'm a little bit I'll push back a little bit on a lot of the changes with Medicaid. I just don't think, like you said, there's a slim majority. I don't think the numbers are there to get big, expansive changes to Medicaid through Congress. I think a lot of it will be done at the administrative level, at the state level. You'll see some stuff with the 1332 waivers, with states kind of tailoring some different programs, that the Trump administration will approve, and differently than the Biden administration did. Some of the pharmaceutical stuff, Trump's a little bit different than the rest of the Republican conference on negotiations. There was one point in his first term that he was pushing for international pricing index. So it's a thing where he could come out and say something and they could shift on that, but which really wouldn't be in line with the way the Republican Party has been before. But he has made it a focus in the first term with regard to prescription drugs. I think one thing that you're going to see that hasn't been mentioned is transparency over API, active pharmaceutical ingredients coming over from China. That's pretty much a bipartisan thing that they've been working on ENC, that I'm hearing they're pretty close to getting some sort of bill done on that. Transparency piece is going to be huge again. A lot of that stuff is bipartisan though. PBM reform is going to be something that Trump's going to want to say he did. I think let's see. I really a couple of other ones I have, association health plans, that HSAs, those are kind of the Republican talking points that they've been saying for years, which is, okay, we want to expand access to these. You have the short-term limited duration plans too, that was kind of clawed back under the Biden administration. We could see that come back around. But any sort of big changes, I just don't see happening in Congress. I mean, when I was up there, I'm not that far removed from being up there, but there's really an unwillingness among the conference to talk healthcare. There's a big educational gap. I could just tell you, like, a lot of the conversations when we had to kind of sell members on different policies, they'd be like, just give it to me in 2 bullet points. I just don't want to dive deep into this. So it's really, really tough to get expansive health policy through, and especially with a 2-vote majority right now. And I'll just say about RFK, he's going to piss me off if he takes my Captain Crunch. He wants to ban cereals and stuff. That's going to really upset a lot of people.
Thank you. Yeah, you're going to have a lot of college kids being very upset about their breakfasts. But anyhow, so quick thing before we jump to Valerie, which is the CLE code. We'll say it again at the end, but just to hear if you're in the middle, if you are looking to get CLE from our presentation today, code is Health 2025. Again, it's Health 2025. With that said, Valerie, why don't we move on to talk a little bit about enforcement? So, as you know, enforcement's a significant issue. It frankly always is. What, if any, changes do we think would occur in the enforcement landscape with the new administration?
Ari, thanks for raising that important point. So under the incoming Trump 2.0 administration, we may see some priority shift in the healthcare enforcement space, but I don't expect a sea change in the overall pace and the breadth of healthcare enforcement. That's for a number of reasons. So at a high level, enforcement usually has a fairly long tail. So typically there's a preceding investigation before you see an enforcement action, and that investigation could take many, many years, can span multiple administrations. And while it's not unheard of entirely, a new administration coming in does not typically put a stop to things that are already well in progress. Also, while there are certainly changes to leadership of enforcement, and we'll talk about that in a moment, there are a number of career prosecutors that have withstood the test of time for decades, in some cases across many administrations. And that too, I expect to remain in place. In other words, the career prosecutors, the amounts that exist, we'll see that continue as well. Let me first touch on the outgoing and incoming enforcement leaders. So the U.S. Department of Justice, or DOJ, they're tasked with enforcing the healthcare laws, the federal healthcare laws, and they represent the federal agencies, including the healthcare agencies, of course, some of which we already spoke about, like the U.S. Department of Health and Human Services, or HHS. and components within HHS, like the Centers for Medicare and Medicaid Services, or CMS. So the DOJ at a high level has a criminal arm and a civil arm. In terms of financial recoveries for healthcare enforcement matters, the lion's share come in through enforcement under a law called the False Claims Act. And the DOJ uses the False Claims Act to obtain financial recoveries, including up to treble damages, as well as pretty significant penalties for funds paid out by the government to which the government does not believe the recipient was entitled for various reasons. DOJ can also assert other meaningful consequences besides the financial damages, like exclusion from federal health programs, and the Office of Inspector General of HHS can also assert monitoring and reporting obligations through corporate integrity agreements that could span many years. There's also, of course, criminal consequences that can happen in the most serious of circumstances, including incarceration. So with that framework, the current leaders of DOJ under the Biden administration have been U.S. Attorney Merrick Garland, and he was appointed by President Biden in 2021 and has been serving since then. And then right under him is Deputy U.S. Attorney General Lisa Monaco, also a Biden appointee serving since 2021. The new leaders that are going to be coming in shortly are, as U.S. Attorney General, are Pam Bondi, who served as Florida's Attorney General from 2011 to 2019. And with respect to healthcare in particular, Bondi was the lead Attorney General in what was ultimately an unsuccessful lawsuit brought by the state of Florida, as well as 26 other states that sought to overturn the Affordable Care Act on the grounds that it was unconstitutional. In her most current role, she's been leading the legal arm of the America First Policy Institute, which is a nonprofit that was planning policies for a potential second Trump term. And right under Pam Bondi would be the incoming Deputy U.S. Attorney General, Todd Blanche, and he most recently served as Donald Trump's counsel in his criminal litigation in New York. And before that, he had experience working in private practice in big law firms and was a federal prosecutor before that. So with that change in guard coming momentarily, the question is, can we expect a tangible difference in healthcare enforcement under the incoming new regime? It may be helpful to address that, to take a look at DOJ's enforcement stats, at least from a financial recoveries perspective under the False Claims Act over the last 10 years. And so thank you, Morgan. You're a step ahead of me. You're pulling up that chart. So I'm gonna reference that chart in just a moment. So while at the surface, one might expect that enforcement could be or would be heightened during Democratic administrations and perhaps reduced during Republican administrations, the data does not quite bear out that neat pattern, at least if we focus in on the Federal False Claims Act healthcare recoveries. So let's take a look at this chart that shows DOJ healthcare enforcement recoveries over the last decade. And these are stats that are published annually by the Department of Justice and are available on their website. So if you take a look, the chart shows Federal False Claims Act recovery by fiscal year, which for DOJ runs from October the 1st to September 30th. And if you look at the overall bars, so the combined blue and orange, that's the overall recovery that DOJ obtained for that fiscal year across all of its False Claims Act enforcement, which a large chunk of it is healthcare, but it's also things outside of healthcare, because there are a number of government contractors on the defense side, in other industries that obtain federal funding that also can be pursued under the False Claims Act. Now, if you take a look at the blue shaded portion of the chart, that portion represents the healthcare focused recoveries, and the orange shaded portion represents the non-healthcare portion of the recoveries. So here's some patterns or some observations based on this. Now, at a high level, and to address the question of what can we expect of this new regime or the incoming regime, it looks historically that DOJ healthcare collections have not ticked down during Republican administrations. So if we take a look at what was ostensibly the first Trump administration from January 2017 to January 2021, which covers the fiscal years on the chart of 2018 to 2020, we see that actually, potentially different from what we would expect, the healthcare component of FCA recoveries, it actually takes up a much higher percentage of overall False Claims Act recoveries, even if the raw dollar amount has stayed relatively steady in that time frame, so in that $2 to $2.5 billion zone. If you compare that 2018 to 2020 fiscal year data to the earlier administration, so the Obama administration, which is reflected in the fiscal year 2014 to 2016 bars, the healthcare portion of recoveries was about half of the overall False Claims Act recoveries. So as a percentage, it's actually smaller, much smaller as a percentage than under the Trump 1.0 term. And then if we take a look at the most recent Biden administration, so that's fiscal years 2021 through 2023, which is the last year of data available, we actually see the trend that we saw under Trump 1.0, where healthcare comprises the lion's share of False Claims Act recoveries. Now, of course, I'd be remiss if I didn't mention that there are these two big outlier years, 2014 and 2021 fiscal years, where the overall recoveries were like double or more of what the general trend has been in the kind of $2 to $3 billion range. Those were due to some significant settlements in those years. So taking this data look back as a whole, it seems that we can't discern any trends that tick and tie to the administration that's at the helm. As a general matter, healthcare, I expect, will continue to be a large chunk of the overall DOJ False Claims Act recoveries for the near term, regardless of the administration. And apart from some policy shifts or policy priority shifts, those general trends where healthcare is going to be pursued and enforced will continue, in my view. One thing I did also want to mention that unlike these sort of dollar recovery statistics, where we have seen enforcement somewhat politicized by virtue of changing administrations, is in memos that the sitting attorney general or somebody very close to that role issues. Those memos, what I'll refer to as those memos, they shift the guidance to the line prosecutors who handle the day-to-day prosecutions and investigations, and then ultimately enforcement and prosecutions of matters they pursue. So just as an example, in 2017, when Jeff Sessions, Trump-appointed Attorney General Jeff Sessions, was in that role, he issued a memo placing restrictions and requirements on both publishing and relying on agency guidance in DOJ enforcement actions. And so essentially saying, hey, the DOJ line prosecutor shouldn't rely on agency guidance in pursuing enforcement actions. It needs to be more than that to build a case. And then the following year in 2018, a Trump-appointed Associate Attorney General, Rachel Brand, sitting in that role, issued another memorandum extending what the Sessions memo said, and essentially wrote that sub-regulatory guidance cannot form the basis of a civil False Claims Act enforcement case. You need more if you're going to bring an enforcement action. So we see that kind of requiring their own line prosecutors to use more to bring a case under the Trump, the leaders of DOJ under the Trump 1.0 administration. Now, in July of 2021, shortly after Merrick Garland took over as the Attorney General appointed by President Biden, he issued a memo that clarified the principles of and actually rescinded the prior two memos that were issued under Trump. And he stated that that those memos were quote overly restrictive and that the implementing regulations under those memoranda have discouraged development of valuable guidance and generated collateral disputes and hampered DOJ attorneys in litigating cases where there is relevant agency guidance that they felt they couldn't use anymore. So, now looking ahead into 2025 with Pam Bondi expected to take over as Attorney General, might we see a Bondi memo sometime this year, rescinding the 2021 Garland memo and hearkening back to those earlier 2017, 2018 Sessions and Brand memos, and saying, hey, line prosecutors, you need more than agency guidance if you're really going to bring a case. We might see that. So that's an area around these guidance memos that we have seen a trend that alters the enforcement guidance depending on the administration in power. So with that, I'll hand it back over to you, Ari.
Thanks, Valerie. Jeremiah, let's move on to a different healthcare and life sciences topic, which is sort of a more focused on what kinds of changes do we think we're going to see at the FDA and its role in the device pharma biologics space with the new administration?
Yeah, it's a great question. And I share John's concern over food coloring and cereals. It's going to be a real issue with my kids. But I do think the interesting thing about the transition to the Trump administration 2.0 is that the nominee to be the commissioner of food and drugs is really a heavyweight, is a medical provider. Dr. Martin McCary is a physician, surgeon, researcher at one of the most elite medical centers in the world, really, at Johns Hopkins. So he is I think shares the secretary nominee's concern over large-scale changes to the health system. He's been published in over 250 peer-reviewed medical journals. He's published a number of books criticizing the over-medication of the country. But I don't know that his concerns are going to radically upend, or his particular prerogatives are going to radically upend how FDA does its standard meat and potatoes work in regulating medical products as drugs and biologics and devices. As everybody here knows, and most folks who are watching online are aware, is that the agency regulates a quarter of the US economy. So 30 cents for every dollar we spend is regulated by the agency. And for medical products, it's a pretty rigid medical product regulatory scheme under the Food, Drug, and Cosmetic Act and the Public Health Service Act. So if you're a drug or biologics or medical device developer out there, I think right now the biggest thing to share is probably the sky is not falling. A lot of the radical change that has at least been intimated in the press is actually in some ways unrelated to the day-to-day submissions and review within the U.S. Food and Drug Administration at the center level. And let me clarify what I mean by that. So the Office of the Commissioner, where I spent 8 years, I served 3 different commissioners, McClellan, who was also a CMS administrator, Dr. Crawford, and Dr. Von Eschenbach. The Office of the Commissioner is the think tank. It's the top of the FDA pyramid. And that's where you see the Office of the Chief Counsel, the Office of the Chief Medical Officer, Office of the Chief Scientist. But as everyone knows, most of the product reviews are going to be done by the different product-centric centers within FDA's organizational chart. So the Center for Drug Evaluation and Research, or CDER, will continue to review drug applications. Center for Biologics Evaluation and Research, CBER, Center for Devices and Radiological Health, or CDRH. I'll refer to this slide in a little bit here, but the sea change actually has come in a couple of those center leadership seats actually being changed through the retirement of what I would say is a couple FDA legends who have retired and moved on to the private sector. What I have seen, though, having lived on the DoD side through Trump 1.0, is that they had 2 commissioners. One was a good friend and former colleague in the OC, Dr. Scott Gottlieb. He and I worked together in the mid-2000s, and he became the commissioner under the first Trump administration. And what I saw there was that there was a lot of latitude given to the commissioner for very specific very specific policy areas that the commissioner has a concern about. So for Dr. Gottlieb, in those kind of 16 to 20 areas, those were things like going after vaping and the marketing to our young people, increasing the price competition for generic drug entry. Those were things like tightening the 510K program. I think that Dr. McCary is going to have a significant amount of latitude to pick serious policy prerogatives. And what we know about his background, I think we could see this emerge to increase the ability of folks to access pharmacy compounded or large scale, what we call 503B compounded products. I think that's a potential opportunity for the agency to do some things that I think the new commissioner would be interested in. I think also looking at, as Valerie mentioned, inspection enforcement is always a prerogative of the agency. I do think that there is a real concern about the international supply chain that leads into all of our medical products. I think that will probably be a prerogative of the new commissioner, is to ensure the agency's oversight and resourced well enough to be able to evaluate the full safety of the supply chain for medical products. Because he's a physician, I think he will continue a lot of what the agency has done ever since the 21st Century Cures Act was passed in 2016 with regard to patient-centric drug development. What I mean by that is the ability for patients and providers to have input into regulatory decision-making, not just with nomenclature, but really using their input to make risk-benefit calculations for specific medical products. So I think those are some kind of big policy areas. It is difficult for one administration to completely untangle, proposed rulemaking and things that have started in that area. But I do think there's a big potential impact in, for example, the laboratory developed test final rule that was issued. That's being challenged in the courts. It's going to be unclear to see how the new administration wants to deal with that. That was a big ticket issue last fall. So I think there are a couple very particular big areas that a new administration would focus on. But I think the overall message here is a lot of the change is not really going to be at the commissioner level. If you could bring up the slide, I do want to share a little bit of a Facebook here, just so everybody understands who is going to be in the new different slots within the agency's leadership structure. As I mentioned, Dr. Martin McCary is the nominee to be the commissioner of Food and Drugs. Dr. Califf, of course, will be exiting after that. That's not necessarily a given slam dunk. As my health colleagues know, that nomination has to go through the Senate Health Committee. We'll learn a lot, both about Dr. McCary's goals and also about the Senate's concerns about anything he may have, any views he may hold with regard to the regulation of medical products through that confirmation process. I personally staff the confirmation process for Dr. Crawford and Dr. von Eschenbach. It's not a gimme, even when you have a slam dunk rock star in the medical profession like Dr. McCary. So we'll be kind of monitoring that. As I mentioned, some of the biggest changes had already been ongoing at the agency in 2024 with the retirement of Dr. Janet Woodcock, longtime Center for Drug Evaluation and Research Director and a good friend and former colleague. She's really a legend within the agency and has contributed her entire career in public health to refining the regulation of drugs there at FDA. So she's moved on, and Dr. Patricia Cavazzoni would be taking her spot. I've had some interactions with Dr. Cavazzoni, very level-headed and very able-bodied leader of CEDAR. Also, Dr. Jeff Shuren is retired and moved on. I think he'll have an emeritus role until sometime in this year. And his young Padawan Jedi, Dr. Michelle Tarver, has taken over, who has shown a real significant commitment to taking a look at the home as a healthcare center, looking at medical devices that can rapidly diagnose pathogens. A lot of real innovations that have come in the medical device space. She's a real driver of change kind of in this area. And there's also some continuity that I think should give everybody some comfort. Dr. Marks, who really led the country from the FDA's chair through the COVID pandemic, remains the Center for Biologics Evaluation and Research Director. So Dr. Marks remains there for CBER. And I know he's been the lead for pandemic response. He's also been the lead for DoD FDA interactions. And also, it'll be very interesting to see. And oftentimes, some of these changes can really impact the agency. It'll be interesting to know if the new commissioner will continue to retain Mark Raza as the chief counsel. I've worked with Mark in the chief counsel's office. He's an outstanding chief counsel and led that office well through the COVID pandemic and beyond. It'll be interesting to see if the new commissioner wants to swap out a new chief counsel. Mark has been at FDA for a long time, has so many experiences in all the different medical product centers. So it'll be interesting to see if he's able to stay. In addition, one individual actually very important that's not on this chart is the chief medical officer, Dr. Hillary Marsden, who was in both White Houses during the COVID pandemic, and she has a substantial role in dealing with pandemic response. So if we think about H1N1, if we think about smallpox or monkeypox responses, she has a very big voice within the commissioner's office. It'll be interesting to see if she is also retained. You can put the slide down now for the time. I'll just close by saying, my comments have been predominantly on the medical products side. We will have an FDA specific webinar at a future date where my colleague Todd Harrison will talk about food and dietary supplements, which is his expertise. So while I think the RFK Jr. Leadership of HHS is going to have some very big ticket sea change goals, I do think that the stability of the agency based on its regulatory framework and the key folks who are staying involved in maintaining their leadership role over medical products, I don't expect radical change. I do think there will be some specific targeted commissioner priorities that we will see significant movement on. That's been the pattern throughout the first Trump administration and onward. So with that, I'll pause, Ari, and get it back to you. I'm happy to answer any questions that folks might have.
Hey, Jeremiah, thank you. Here's the time at which we'll jump into some questions. One of our first questions was just generally about sort of what do we think? I think about the state of investment in healthcare in 2025 and what do we expect? And my sense is this: I don't expect the increase in investment in healthcare that's actually picked up at the end of 2024 to just slow down in 2025. Now, against that, there has been and continues to be, and I expect it to continue to sort of the dominoes to fall, state level regulation of healthcare M&A that has been bipartisan. And that's been very significant, looking at things like antitrust issues and quality and services to the poor and or indigent and those sort of healthcare transaction rules that have been jumping across many states and being implemented. I don't expect that to stop in 2025. That's particularly a state law issue, and so you're going to see more transactions. I think the transaction activity is going to pick up, but I also think that you're going to have more state-level regulatory issues in the transaction landscape. And I know Elisa has some thoughts just about federal issues with respect to healthcare transactions, and so I'm going to put it off to Elisa.
Sure, thanks, Ari. I think what we saw in the past session of Congress is growing bipartisan interest in examining what's called consolidation among health and hospital systems and the acquisition of physician groups by health and hospital systems. There were several hearings about this, and members of Congress, both sides of the aisle, on committees of jurisdiction, looking at this issue and examining the impact on consumers, on choice, on access to care. I think that there will continue to be that interest. I also know that there are several health and hospital systems that have saved rural hospitals from closing. And so not all consolidation is viewed by members of Congress as a bad thing. Many members of Congress appreciate that their local hospital still has the lights on because of an acquisition by a larger health system. So like many of the issues we've talked about today, it's complicated. And to John's point earlier, not all the members of Congress always take the time that's necessary to really unpack and dig in to the issues and the nuance. But I think we will continue to see those issues discussed in the Congress. There's also third-party stakeholders who are getting involved in the conversations around the impact of consolidation and various narratives. And I think our group has worked really hard on behalf of our clients to ensure that their voices and their lived experience and the impact on the communities they serve has been heard by policymakers.
Thank you, Elisa. Why don't we had another question just about I don't even know how to say it. I'm not even going to say the acronym. I'm just going to say about the administration's interest in real regulatory efficiency, regulatory reform, and sort of how do we think that's going to impact healthcare issues. John, Jody, Elisa, I forget which one of you thought you would start with it first, but I'll throw it to one of you.
I'll start with the Doge, and that is how you say it, the Doge.
I think that's the uniform pronunciation. I think we've got it now.
Yeah.
Not a Medici thing or something.
I don't know what it is, but it doesn't really make much sense. But I think, there's a lot of talk inside the Beltway about it, but, Elon Musk is going to go through different agencies and just start axing people. I think, where public opinion is that the federal government's a little too bloated. And I think that they're going to play into that. What they can actually accomplish, I don't know. In talking to a lot of people, I think there are a lot of federal workers that are up for retirement anyway, that are gonna kind of eliminate a good bit of positions, and maybe they just don't fill those, and they take that as, oh, well, we cut 20% of the workforce. But in terms of kind of their effect, on the legislative process, the Congress had to start a caucus in both the House and the Senate, because there really isn't much that the committee could have done itself. A lot of this has to be done through Congress. Now, I can tell you, there are some committees for reconciliation that have written language that would eliminate different sub-agencies, different positions within the federal government. But again, I don't know how that all plays out. I don't think it's going to be anything earth-shattering. And again, like I said, if we start seeing a reduction in the federal workforce, it's something that outside of DC, public opinion is probably in the Trump administration's favor in that.
Yeah, I think just adding on to what John said, DC's history is littered with a graveyard of thoughts on government efficiency and savings. They certainly have momentum. They, again, can't do it without Congress. I think it's going to be, if they succeed in any of it, will be much more modest than what they are talking about. Things like forcing workers back into their offices. You could see turnover because of that. You could see some buyouts. You could see some workers that just, are in line with what this administration is doing or thinking. But there's everything from labor agreements to lawsuits to other things that are going to play out if there's any sort of attempt to do large scale changes to the federal workforce. So I think it's going to be much more modest than if they succeed, much more modest than what they talk about. But it's I think, you know, Jeremiah might talk a little bit about it's certainly at FDA, but all government agencies, that means a lack of expertise. And if it takes government workers to promulgate regulations and rules, it takes government workers to undo regulations and rules as well. So they may find they don't have all the people they need then to enact their agenda. But Jeremiah, I didn't know if you wanted to jump in with anything on that.
Yeah, it's a great point. I think John's point is a great one as well. I think a lot of what is anticipated is just going to come through, you know, what I've seen is every administration changes, issues a hiring freeze, and they don't replace people. But I can tell you, I was on a panel with Dr. Marks, the director of CBER, at a recent OWS 2.0 conference here in the city, you know, and he expressed publicly a very significant concern over losing the scientific expertise within the agency. Now, we were talking, of course, about the COVID pandemic response and kind of he's got some proposals that have actually made it to the Hill within FDA's larger legislative proposal to essentially create a medical countermeasure, you know, review team that's specific to that. But the idea of losing folks who have helped us navigate the last, you know, 5 to 6 years is a significant risk. And I know there have been a lot of comments about the, you know, the conflicts of interest presented by the prescription drug user fee framework, or what all of us know affectionately as PDUFA or MDUFA or GDUFA or BASUFA, any of the user fee statutes. Those I've seen been attributed to the nominee for the Secretary of HHS, RFK Jr. I haven't heard that from Dr. McCary, the nominee for Commissioner of Food and Drugs, but I also say, as everybody here will affirm, those are functions of a congressional statute. Those frameworks aren't going anywhere. And to think that the staff or even PDUFA itself is going to go away in the short term, that's not going to happen. I mean, the review process would come to a halt without the funding via the user fee statutes of guaranteed review clocks for medical product applications. So I think a lot of people would be up in arms if we see any real legitimate threat to that framework, but that would also require congressional engagement.
Jeremiah, thank you. I'll give a broad comment, and I think Elisa, I might put you on the spot because I think you may have, in our internal conversation, you may have something to add to this, but which is that, you know, we have a tripartite government. We have checks and balances. We have lots of things that allow us to regulate in certain ways. And it's really nice on the campaign trail to say, I'm going to get rid of X or I'm going to do Y. Accomplishing that, you know, with a flick of the wrist is just not possible, right? You don't get to say, I'm getting rid of the Department of the Interior and letting everybody drill wherever the heck they want to drill, right? Just because you feel like it. There are statutes that may in fact prevent that, right? And so so I just want folks to recognize that too, that the bluster of any campaign, and whatever side of the aisle you're on, right? It doesn't necessarily mean that those things can be accomplished. And at least I think you had other thoughts on that too.
That's right, Ari. And obviously some things require statutory change. And as Jeremiah lifted up, several of them, you know, within the FDA purview would require change to the Food, Drug, and Cosmetic Act and the User Fee Act, all the UFAs, as we lovingly call them. Others would require the, you know, notice and comment. So even if it's something that doesn't require a big A act of Congress, it might still require public notice, proposed rulemaking, public comment, review of those comments, promulgation of proposed and final regulations. And so there's a lot of steps between a campaign promise or an idea that someone, whether they're running for office or just supporting someone for office, might be putting forward. And as Jody said, you know, maybe this is showing our age, but I started working in Washington in 1993, and I remember Al Gore's Reinventing Government, the REGO effort. So we were going to be doing, you know, government efficiency and reinventing government in the 90s. So these things have their own trajectory. Both sides of the aisle seek to do them. Certainly, I think everyone could identify some part of government that could work better or could be improved in some way, some programs that may have, outgrown their utility or funding that might be used elsewhere. But the challenge, of course, in what we do, John, Jody, and I, and our colleagues, is what's somebody's inefficient program is somebody else's pet project. So so you don't always want to be lifting up something for elimination, because you might very quickly find yourself facing a very fierce opposition to that. And so I think it's always good to be looking at ways that our government can improve its functioning. But actually, to your point, Ari, making wholesale change with the flick of a wrist is much harder. Even with executive orders have their limitations in terms of what can be done. And I know we're anticipating lots of executive orders noon on January the 20th. But the president, just like Joe Biden was limited, President Trump will be also limited in his ability to utilize that tool in his toolbox.
To wrap this up, I am anticipating lots of breaking of expensive government equipment on late night TV that I'm really excited about, all in the interest of government efficiency. And I want to thank everybody, all my colleagues, for spending some time today talking about this very important topic. I want folks who are on, I just want to thank you for joining us. Really appreciate it. We have a whole bunch of other upcoming webinars on things that we expect under the second Trump administration that are very specific to other types of topics. Please feel free to join us. We'd love to have you join us. Reminder of the CLE code, Health 2025. If you are going for CLE, you will be getting a link to do your evaluation of the program, and there'll be a place to put in the code, Health 2025 again. So thank you for joining us today. Really appreciate you being here. Take care, everyone.